Okay, so why don't we get started? So welcome everyone to today's ACLP Virtual Journal Club session. As a reminder, we're working our way through the ABPN's article-based pathway for maintenance of CL subspecialty certification. In our next session on September 13th, Dr. Sarah Andrews from Johns Hopkins will present a review article about ways to promote adherence in individuals who have undergone organ transplantation. If you are interested in presenting at a future journal club, please let me know and we can certainly discuss it and figure out how we can make it happen. So for today's journal club session, I'm very pleased to introduce Dr. Scott Beach. Dr. Beach is an Associate Professor of Psychiatry at Harvard Medical School and an attending psychiatrist on the Psychiatry, Consultation, and Acute Psychiatry services at Massachusetts General Hospital. Dr. Beach's interests include QT prolongation, catatonia and related syndromes, the neuropsychiatric effects of COVID, and deception syndromes. He's authored dozens of peer-reviewed articles and book chapters, and he has edited several books. So today, Dr. Beach will be discussing his 2018 article entitled QT Prolongation, Torsades de Pointes, and Psychotropic Medications, a 5-year update. In terms of logistics, Dr. Beach will speak for about 20 minutes, and then we should have about 9 minutes for questions. If you have any questions, please use the Q&A feature below, and I will try to get through as many as I can at the end of the presentation. Yeah, so that's it. Now with that out of the way, Dr. Beach, please take it away.
Thanks, Chris. And I'll say as I'm pulling up my slides that I realized because Chris shared his link with me that I am labeled as Chris Solano, but I assure you that despite frequently collaborating, we are actually different people. I'll start by thanking all of my collaborators for this article, including Chris, and also a thank you to Chris and Margot Funk for some of their slides, which we've used in prior presentations that we've given together. So I'm going to jump right in and try to get through this in the 20 minutes. So as Chris said, we're talking about a review that was published in 2018. It was written mostly in the summer of 2017. And it's a little bit unique. It's a 5-year update on a review that we had initially published in 2013, written in 2012. And our interest in this issue was really kicked off by the FDA warning regarding citalopram, which happened in 2011. I was fresh out of fellowship and just joining the cardiac psychiatry research group. And so we got really interested in this issue. And what we wanted to do was to write a really practical review that would be useful to CL psychiatrists and that was focused on the data that had come in the last 5 years since we wrote the initial review. So as a reminder, what we're talking about today with regards to QTC prolongation is really about torsades de Pointes. So that's the outcome that everybody is concerned about when we think about QTC prolongation. It's a malignant polymorphic ventricular tachycardia, and we worry about it because it can present as sudden cardiac death. It is difficult to classify how frequent it is, but we know that it is a fairly rare event. So 1 in 12,000 to 1 in 120,000 patients, but it's associated with high morbidity and mortality up to 1/3 of patients. Most cases occur in the setting of either congenital or acquired long QT syndrome, and that's why there's this association with QTC prolongation. And we've looked at that, people have looked at that in terms of whether QTC is actually the best marker of risk for torsade. At this time, the answer seems to be yes, but it's important to keep in mind that in the absence of other risk factors, drug-induced QTC prolongation rarely leads to torsade. Other things have been looked at as better markers of torsade. For a while, there was this excitement about QT dispersion, but that really hasn't borne out as a better marker. People are also thinking about T-wave and U-wave morphology as important markers for risk, but those are a little bit more difficult to classify. And so right now, we still believe that QTC is the best marker of risk, but it's an inexact marker, and that's important to keep in mind. When we think about other risk factors for torsade, we are dividing them generally into non-modifiable and modifiable risk factors. And these are risk factors that all CL psychiatrists should really be familiar with. So things like female sex, which is associated with a higher risk for torsade, Advanced age, so the older somebody is, the more at risk they are. Another good rule of thumb is the sicker somebody is, the more at risk they are, particularly if they have cardiac issues. And then we think about modifiable risk factors. Big ones are medications, so use of multiple drugs that may prolong the QTC, or thinking about drug-drug interactions. Drug toxicity is also a risk. There are some electrolyte abnormalities that constitute significant risk. So we should be thinking about hypokalemia, hypomagnesemia, and also hypocalcemia. Hepatic and renal failure or impairment will also convey risk. And the big one that often gets missed that's on this list is bradycardia. And in my mind, that's one of the most important risk factors for Torsades, and one which we really need to be aware of and be keeping a close eye out for. When we think about correcting the QT formula for rate, or correcting the QT interval for rate rather, we have a variety of formulas that have been designed to do that, but it's important to recognize that not all formulas are created equal. The most common formula you will encounter, and the formula that almost all EKG machines will be pre-programmed to, is the Bazet formula, which is a square root formula. And the big thing to recognize is that Bazet is probably actually the worst formula when it comes to correcting the QT, and I'll show you some evidence of that in the next couple of slides. So there are other formulas as well. There's Fredericia, which is a cubed root formula. There's a bunch of linear correction formulas, which include Framingham and Hodges. There's even a QT nomogram that's been designed. This is a study, this is a graph from the Penn atrial fibrillation study, which compares some of the methods for correction. The Bazet formula is there in red, and you'll notice two things. One is that it tends to overestimate the QTC, so it's shifted to the right, and the other is that it has a wider area under the curve, and it kind of separates out from the others, Fredericia, Framingham, and Hodges, which group together. This is another study showing a similar thing. As you get to higher heart rate, Bazet's really goes off the chart in terms of not being an accurate correction formula, whereas the others tend to group together. And there's good evidence now from studies that if you use Bazet formula to correct, you will needlessly reduce the opportunity to use some medications, including haloperidol, because of concerns about QTC prolongation. There are some situations in which it's particularly hard to estimate the QTC. One of those is when you have a widened QRS, and that might be from a bundle branch block, it might be from ventricular pacing. A widened QRS is related to depolarization, but when we think about Torsades and QTC prolongation, we're mostly concerned about repolarization. And so widened QRS doesn't necessarily correspond to an increased risk, or we might think about it as a different kind of risk. In that situation, there's no agreed upon correction formula, but you should have one correction formula in mind that you can use to correct. And some people use the JT interval, some people use the JT prolongation index. A newer formula that's been developed is the Bogassian formula. And then there's even a quick and dirty version. So you should have one of these kind of in your wheelhouse to correct for a widened QRS. And it's important to keep in mind that the presence of pacemakers or AICDs should be considered a marker of risk. Yes, those things may protect from Torsades if depending on the settings, but they also indicate that somebody is at a greater risk for arrhythmia by virtue of having them. Another situation that is hard to correct for is atrial fibrillation. The recommendation is usually to average multiple complexes, so either to average a bunch of complexes or average the longest and the shortest. One thing to keep in mind is that atrial fibrillation may be somewhat protective against Torsades because it's associated with tachycardia. And again, we think of Torsades mostly occurring in the setting of bradycardia. So that's some background on correction formulas and approach. I'm going to spend the rest of the time talking about medications. So let's start with antidepressants. So I mentioned that this all kind of got kicked off for us with the FDA safety warning about citalopram. That still stands. Citalopram should not be used at doses greater than 40 milligrams or at doses greater than 20 milligrams in those with liver dysfunction or over the age of 60. That recommendation was based on a thorough QT study, which is kind of the gold standard when we're trying to determine if a medication causes QT prolongation. And that showed 8.5 milliseconds of prolongation at 20 milligrams of citalopram and 18.5 milliseconds of prolongation at 60 milligrams of citalopram. You'll note that they did not study 40 milligrams of citalopram. There is lots of evidence since that time supporting the idea that citalopram probably does separate out from other SSRIs in terms of its propensity to prolong the QT interval, and on average causes somewhere between 5 and 20 milliseconds of prolongation at therapeutic doses. The evidence is less clear, however, for the relationship between citalopram and Torsades, and a couple of large studies suggest that citalopram is not necessarily associated with an increased risk of Torsades. So the way that we interpret the cumulative data is that perhaps citalopram does increase the QT interval, but the actual risk of Torsades associated with that increase is not clinically significant. It's really important to keep in mind that prescribing lower doses of citalopram also has significant risks. And there are good data now that patients were prescribed lower doses of citalopram reflexively in the setting of the FDA warning. Interestingly, older adults were less likely to have their doses reduced to under 20 milligrams, but many patients had their doses reduced to under 40 milligrams. That reduction resulted in increased rates of psychiatric hospitalization, increased mortality, and more frequent prescriptions for sedatives or anxiolytics, as well as higher healthcare utilization. So a take home here is if you inherit a patient who's on, say, 60 milligrams of citalopram, you should not reflexively reduce that dose without carrying out a careful risk-benefit analysis, because the reduction in dose can have significant risks. What about escitalopram? So a similar pattern of dose-related QT lengthening was demonstrated in a thorough QT study, though to a lesser extent, and there's no FDA warning. Escitalopram does separate out in some studies, but it's not associated with greater mortality or greater rates of Torsades in a large cohort study. And in a meta-analysis of patient-level data, the mean QTC increase was only 3.5 milliseconds, and only one patient had what would traditionally be considered clinically significant QT prolongation. So overall, we think that escitalopram may carry some risk of mild QTC prolongation, but it's unlikely to be clinically significant. Thinking about antidepressants more broadly, SSRIs are largely considered safe. So they're the most studied medications in cardiac populations when it comes to antidepressants. Notably, though, all agents except for paroxetine do have case reports linking them to QT prolongation and Torsades. But generally, we think citalopram is probably a little bit different than the others, and the others can largely be considered safe. Tricyclics have been known for a long time to widen the QRS interval. They pose a danger at therapeutic doses, primarily in patients with pre-existing heart disease, and then also may pose a danger at toxic doses or in overdose settings. In terms of other antidepressants, aside from citalopram, the antidepressant with the most evidence for QTC prolongation is probably venlafaxine, but most of those cases have occurred in the setting of overdose or in patients with significant other risk factors. So for that reason, if I had somebody who had multiple risk factors for QTC prolongation, I probably wouldn't reach for venlafaxine first. That being said, I think you can make a compelling argument to use it in at-risk populations. Bupropion has a few reports of QTC prolongation in the setting of overdose, but those are probably confounded by the use of Bazette formula and by the tachycardia that would occur in the setting of a bupropion overdose. Mirtazapine is an interesting one. There's a little bit of a signal, but the study that showed a signal linking it with increased sudden cardiac death hesitated to make any causal association. And there's another study that actually shows a lower risk of cardiac events than other antidepressants. So overall, I don't worry about QTC prolongation in terms of mirtazapine. Other newer antidepressants really don't have any signal at all. Let's talk about antipsychotics for a minute, and then at the end, we'll circle back and talk about some practical recommendations for both groups of medications. Typical antipsychotics as a group are thought to lead to modest QTC prolongation compared to placebo, but the effect is probably primarily driven by phenothiazines. And in general, low potency agents are thought to cause more QTC prolongation than high potency agents, with low potency phenothiazines being the most associated with QTC prolongation. That class effect is probably primarily driven by thioridazine, which is the worst offender across all antipsychotics, but low potency phenothiazines are overrepresented in cases of sudden cardiac death. The risk, as it is for all of our psychiatric medications, is likely dose dependent. Intravenous haloperidol, I want to make mention of because it has a unique warning from the FDA in 2007 that recommends continuous telemetry for all patients receiving IV haloperidol. That's based on case reports. But a 2010 systematic review of 70 case reports suggested that 97% of them had other risk factors present. IV droperidol was also covered in this review article, and it turns out that there is a risk for QTC prolongation and torsade, but that risk is probably minimal at doses of up to 10 milligrams. IV droperidol has enjoyed a little bit of a resurgence in the past 5 years in emergency room settings. Its use is now endorsed by the American Academy of Emergency Medicine, but really only in doses up to 10 milligrams. And what's important for us to recommend is to recognize is in settings in which there may be a need for ongoing medications for agitation, that dose range becomes very limiting because a typical dose of droperidol for agitation is 5 to 10. So that really only gives you 1 or 2 doses before you get into range where you have more concern for QTC prolongation and torsade. This is a graph actually from a study that came out after our review article, so apologize for fast forwarding here a little bit, but it's a nice comparison of the different atypicals in terms of their propensity to prolong the QT interval. You can see that there are some like lorazepam and aripiprazole, which actually perform no differently, maybe even a little bit better than placebo. And then if you look at the classic antipsychotics that we're using on the consult service, quetiapine, olanzapine, haloperidol, risperidone, they all group together sort of in the middle. And that's really one of the key take-home points here, is that especially most atypical antipsychotics really kind of group together, and it's hard to separate them out. You'll see the worst offenders here are ziprasidone and iloperidone. A reminder that ziprasidone has a black box warning, and it has an average QTC prolongation of 10 to 20 milliseconds, but about a fifth of patients experience prolongation of greater than 60 milliseconds, which we would consider clinically significant. So ziprasidone is definitely in the high risk category. Quetiapine is another interesting one that I just want to highlight because among the atypicals and among the agents that we use on the consult service, it's one that actually has a strengthened FDA warning. And that warning suggests that it should be avoided with other QTC prolonging agents, those patients with a history of arrhythmias or metabolic deficits. It's based on a handful of case reports, and overall the data on quetiapine remains mixed. But interestingly, there's one study suggesting that about 10% of people experience a prolongation greater than 20 milliseconds. So the take home here, I think, with quetiapine is it's probably somewhere in the middle, but certainly don't make an argument that quetiapine is safer than other medications that group in the middle with regards to QTC prolongation. So in summary, for antipsychotics, low risk, aripiprazole and lorazepam, medium risk, pretty much everything, haloperidol, chlorpromazine, olanzapine, risperidone, and quetiapine. High risk, ziprasidone, iloperidone, thioridazine. So again, most of our antipsychotics group in that moderate risk range where it's really hard to separate between individual agents. There is mixed data about whether antipsychotic polypharmacy leads to greater QTC prolongation. If that's true, it probably has to do more with cumulative dose than with the fact that multiple agents are being used. So again, it's probably a dose effect. To end, let's talk about some practical recommendations for meds. So if you're using antidepressants in the outpatient setting, keep in mind that the overall magnitude of QTC increase with SSRIs is small. There is no indication for baseline EKG with all antidepressant initiation, but you might want to consider a baseline EKG for patients with significant risk factors who are being started on something other than citalopram. Citalopram does appear to be the worst offender, but again, the actual QTC prolongation remains minimal. That being said, it's not my first choice for patients with pre-existing cardiac disease. I'd probably reach for sertraline in that setting just because it's been the most studied. And I would consider a baseline EKG for patients being started on citalopram, even if they don't have other risk factors. If they do have other risk factors and you're making a compelling case for using citalopram, that's a situation where I might actually consider a cardiology consult or at least a curbside to talk it over with one of my cardiology colleagues. That being said, again, do not reflexively reduce the citalopram dose without doing a careful risk-benefit evaluation, because a compelling case can be made for not only using citalopram in somebody who's at risk, but also for using high doses of citalopram. But it just needs to be done judiciously, and you need to think about EKG monitoring in that situation. When you're using antipsychotics in the outpatient setting, again, there's no indication for a baseline EKG with all antipsychotic initiation. You could consider a baseline and a follow-up EKG for patients with significant risk factors who are being started on a low or moderate risk antipsychotic. You could also consider a baseline and a follow-up EKG for patients without risk factors who are being started on a high-risk antipsychotic. So if I was starting ziprasidone on somebody without risk factors, I probably would want to check a baseline and a follow-up EKG if possible. For patients with risk factors who are being started on a high-risk antipsychotic, then you might consider ongoing EKG monitoring and maybe even consultation with your cardiology colleagues. And you want to avoid the use of multiple antipsychotics in patients who are at high risk for torsade. On the inpatient setting, you should assume a higher risk for torsade. We have increased access to monitoring, so we're often a little more aggressive with our monitoring. So we probably do a baseline EKG before starting any antipsychotic if possible. Follow-up EKGs for patients with risk factors or receiving a high-risk antipsychotic, maybe a high dose of a moderate risk antipsychotic. You want to be sure you're repleting electrolytes, and you want to consider alternative agents if the QTC gets above 500 or above 525. But again, it's always a risk-benefit analysis. There's not an absolute cutoff. Lastly, I just want to mention some limitations. This is not a systematic review, it's a narrative review, so we may have missed data that was available at the time. There are very few head-to-head trials, there are very few thorough QT studies, so the data is limited in that way. And even as much as we've trashed the Bizet formula, it's still the most used in most studies. Torsade is a rare phenomenon, and that also makes it really hard to study as well. I'll end there. Again, big thank yous to my collaborators, Chris Solano, Jeff Huffman, Caitlin Adams, Peter Noseworthy, Alan Chagru, Michael Ackerman, Jim Januzzi, and Margot Funk. They've all been really important to these articles as well as to this presentation. Thanks.
Wow. Well, thank you, Scott, for all of that. You covered a lot of ground over the course of 20 minutes. So that's all been great. We do have a couple of questions, but if you do have a question, please put it in the Q&A function and I can certainly pass it on to Scott. One person was wondering if you could comment on the risk of torsades in patients with an ICD or LVAD, and is there a need, kind of how would you think about those folks in terms of risk and approach to QT monitoring?
Great question. So when I was a fellow, I used to be really reassured by that. I was like, oh, this person has an AICD, so we don't really need to worry about torsade. And that's kind of the completely wrong approach. So what you should be thinking is, wow, this person has an AICD, which means they have significant cardiac disease. And if they have significant cardiac disease, that's a real risk factor for torsade and for more cardiac disease. So I think about those things as a marker of risk. And yes, an AICD may be protective, but keep in mind that patients have compared the firing of an AICD to being kicked in the chest by a mule, and it is highly associated with PTSD. And so it's really an event that you want to avoid. You do not want to set somebody up to have their AICD fire. So I really think about those as markers of risk. And when I'm doing my risk-benefit analysis, I think about that as something that increases the patient's risk for having torsade or another arrhythmia.
Great. How do you weigh the risk of torsades when giving antipsychotics for acute agitation as opposed to scheduled treatment?
Yeah. So that's, I think, one of the most common challenges on the consult service. And I would say, I think about a couple of things. One is we think that with all medications, the risk is dose dependent. So if you are giving a one-time agent, that is probably lower risk than if you're giving something in an ongoing fashion. The other thing that you have to think about practically is, if somebody is wildly agitated in the ICU setting, you are probably not going to be able to get an EKG on that person before you have to administer the agent. And so that's really part of your risk benefit analysis. In my mind, if somebody is about to rip out their central line in the ICU, that is a greater risk than the risk of potentially prolonging their QTC with IV Haldol. So in that situation, I would give IV Haldol even if I don't have an up-to-date EKG, or even if I think there's some risk involved, because again, I'm trying to mitigate what I see as a greater risk. But it's a tricky situation, and I would say even when you're using one-time doses for agitation, it's ideal if you have some data to go on. So if you have an EKG from that morning, that can be helpful data as well. The main thing I want to emphasize for people, I hear this all the time from our trainees and from junior faculty, is I'm going to use this agent for agitation because it's less likely to prolong the QTC. That is rarely true. We're not typically giving aripiprazole for agitation. And at least at our institution, we aren't using a lot of ziprasidone. And so usually our choices are all moderate risk agents. So I would never choose olanzapine over IV haloperidol because I think olanzapine is going to be safer for QTC prolongation. There's actually no data to suggest that that's the case. And so you want to choose the agent that you think is going to best treat the agitation and be best for the patient, recognizing that it's really hard to separate out agents in terms of QTC risk.
Great. If you had a patient who had prolonged QT interval, like 600 milliseconds, and they're in the ICU and they're agitated, and you think that the antipsychotics are contributing to it, what alternative agents might there be?
Yeah. Great question. So that is a very tricky situation. I have a couple of things that I think about. One agent that I don't love all the time for delirium, but I love in a situation like this is IV Depakote or valproic acid. Can be given IV, is easy to administer in that way, can be really useful for impulsivity and agitation, works particularly well in patients who may have an underlying major neurocognitive disorder or TBI, but even in somebody who's just delirious can help a little bit with impulsivity. So I might reach for that. I would think in the ICU setting about Dex, but I want to caution something with dexmedetomidine. Dexmedetomidine does not prolong the QTC interval, but it is associated with bradycardia. And so if you're going to use dexmedetomidine, you just want to be careful that you're not taking that person with a QTC of 600 and suddenly making them bradycardic, because that may actually increase their risk for torsade. But sometimes you can get away with using a low dose dex, particularly if somebody is very agitated, and not necessarily inducing bradycardia in a way that significantly increases their risk.
Great. So maybe we have time for maybe one more. What would your go-to equation be to correct the QT interval for heart rate?
Yeah, so the American Heart Association recommends a linear correction formula. And of the linear correction formulas, I really like Hodges, because it's the only one that doesn't require you to have the RR interval. So it's just easier. It's derived using the heart rate. It's one that is really good for kind of a quick and dirty estimate. It's a linear correction formula. So it's significantly better than Bazette's when the heart rate deviates greatly from 60 beats per minute. So we tend to use Hodges as a first pass. There's a little bit of evidence suggesting that Framingham is probably better. So if it was really on the edge with Hodges, I might correct with Framingham to get a more exact estimate, but Hodges works well in most situations and is going to give you a good estimate, and is a pretty easy one to remember.
Okay, awesome. Well, thank you, Scott, again for coming and talking with us. I'm sorry to everybody who whose questions we couldn't get to today. I will say that we did get some questions about whether or not these recordings are available. And so I wanted to show you that yes, in fact, they are. If you come to the ACLP website and you go to For Members and you come down to Academy Webinars, this is one of the Academy webinars. So you can see all of the ones that have been done before. And after this is done, this will be posted on there as well. So thank you everybody for coming. We will have our next one on September 13th with Dr. Sarah Andrews on promoting adherence in patients with organ transplantation. But again, thank you, Scott, and thank you all for coming to the webinar.
Thanks, everyone.
Bye, everybody.